Hi, everybody. Thanks for joining us. Thank you too for the invitation. As Nikki said, I didn't specifically prepare some slides for tonight because, well, in my innocence, I thought it actually was going to be a Q&A. But apart from that, I do think sometimes when a speaker has, how can I put it, prepared a presentation, it's not always what you want to hear. So I'm very aware that you may have questions, and some have been sent in already, which is really helpful, that I might not cover unless we have a chance to talk. I also appreciate that in a relatively big group, it's not so intimate. People might not feel quite comfortable enough to speak or ask questions. So do pop things in the chat as we go along. I'm going to tell you a little bit about me. I work at the Royal Free. I've been a consultant here for 20 years now, and my specialty is called palliative medicine, and I work with the hospital specialist palliative care team, which is essentially a nurse-led service. So I'm kind of the medical backup to a team of specialist nurses, and we also have a community team based at the Royal Free, which goes out and visits people at home in the local area. I had worked at Marie Curie Hospice Hampstead all of that time up until December last year, when it was forced to close because of the discovery of the dubious aerated concrete rack, which was holding up the floor with all the boilers and everything else that was heavy. So it's very sad that the hospice has actually had to close. So I've got experience across all those different areas of caring for people at home, hospice and hospital. And of course I work in the same hospital as Professor Kaplan's team, and I'm guessing many of you may come to the Royal Free for treatment and follow-up and so on. And of course we do see some people who need some help with symptom control and so on, when they're either inpatients or coming as outpatients to the hospital. Palliative medicine, by the way, I think, hopefully reassuringly, it is not simply about the last days or weeks of life. It's definitely a specialty which will be interwoven with the journey that people go through, whatever their underlying condition, be it a type of cancer or something like heart failure or another long-term condition that causes, well, ups and downs, to put it mildly. And so we don't necessarily become a permanent part of someone's care, but we may go in and out of their care, and depending on need. However, of course, we do care for people as they are coming towards the end of life. So on that note, I don't really want to, what's the word? Dwell on things really that might not be what you will want to think about, talk about. And I just wondered if anyone would be up for a bit of a conversation about any aspect of living with neuroendocrine tumor or anything else, actually, more general. And if you don't say anything, I'm going to fall back on some questions that were sent in, which is great. I have also got some slides, which I'm going to keep up my sleeve just in case you're all too shy. Oh, by the way, I know I'm a doctor. I'm employed at the Royal Free, but we're out of hours now, so you can ask me anything. and I will talk about it, hopefully in a way that is not dubious, if I may say. But don't be shy about asking me anything. And I appreciate there are things that crop up not infrequently in the media that may be relevant, put it that way.
So I'm going to perhaps kick off with a question. It wasn't one that was pre-submitted, but I think it might help open, maybe prompt some comments or something. It's around decision making, because I think being diagnosed with neuroendocrine, many people have had some people have had quite a straightforward point to diagnosis. Some people have had a very difficult journey to get their diagnosis and then understanding. There's an awful lot of information that's thrown at them, and there's decisions that sometimes have to be made under a pressure of time, but other things that are decisions about future and thinking about what next. What kind of things can help people in managing, sort of trying to find the information they need, but also in having those discussions, in opening up those discussions?
It's a really good question. I think many of you probably have experienced one of the biggest deficiencies in our system, and that is time. We just struggle to find time for people. And also, because of the way our system works, you may have an appointment and then there'll be a whole load of things that happen, investigations and so on, waiting for test results, and before you get another chance to come back, and it'll be in a clinic which is busy, and depending who's around, you might see the same person, but you may see someone new, and it's like, how do you get a rapport? How do you have, I suppose, the comfort and the confidence to be able to ask all the things you wish to ask, knowing that there's a dirty great big queue, and your appointment was at 2 and it's already 3:30. I think that's the biggest challenge, really. However, what I would say is, if you're in a position where you've been given a whole stack of information or options that you have to consider, or is new to you, and you need to have some time to think it through and formulate some questions, do just that. Take a list with you of questions I need to ask, and if you can, stick the number one priority at the top of the list and work your way through. I do think that working with not just the neuroendocrine team at the Free, but other specialty teams in oncology, renal, all the different medical specialties and surgical specialties combined, if there's a clinical nurse specialist team, they are often the ones who have the time, not always, but a bit more time, to really pick up on questions that haven't been answered or need more information. So if you have a connection with a clinical nurse specialist, that is really helpful. I appreciate it's not always possible. There are sources outside, and I'm sure you because you're all here on Zoom today, I'm sure you're pretty good at the old internet. So if you look, I mean, I know the internet is a risky place to go to, but look on, I suppose, those sites that are going to be more likely to be, shall we say, reputable. Macmillan is a very good source of information, general and sometimes specific to different conditions. And there will be others like the Neuroendocrine Tumor website that we're all privy to. I think we've got to be careful about, how can I put it, information that's coming from unverified sources, or Fox News, for instance. So just, be a little bit cautious about where you get that from. And then there's the bewilderment that is understandable, especially at the beginning. And you might be have a diagnosis that's made in your local hospital, and then they say, well, actually, we need to send you 78 miles down the road to the Royal Free, and you think, oh my God, what does that mean? And no one that you know has ever heard of this thing, and that is a really unsettling, I can imagine, unsettling situation. So I think that makes it even more important that you get some, as it were, kosher information that can start to make sense of everything that you've been told. And then things change. And so your questions may change. I think the fact that you're all here hopefully means you're, well, likely to be keen to know, keen to engage, seeking information. And that's key, I think. And if you have people who are near and dear to you, I think it really is helpful for you going through all this malarkey to have those people with you and sharing that information as much as possible, as much as you wish to. I'm whittering on now. There must be another question. Stop me.
I guess the follow on to that then is we talk a lot about uncertainty and managing it. And alongside sort of some of the decisions is, unlike some of more common cancers when a lot more people experience it, so we've got a lot more, I guess, evidence or real world experience. Trying to make a decision where the evidence you're given may not be as strong as it would be if you had something else. What kind of things can help people in sort of, approaching that or dealing with that level of uncertainty?
I think that is a really common difficulty across not just oncology, but other areas of medicine where we are dealing with essentially any treatment or procedure, operation, whatever we as doctors feel might be a good option for you. There will be a percentage chance of benefit, which may or may not be, accurate, versus a percentage chance of either no benefit or worse, toxicity of treatment or adverse effects from surgery, for instance. And I don't know the answer, Nikki, really, apart from each person having the opportunity to weigh it up for themselves. I think there is a little bit of self-awareness involved here, and I think particularly at the really uncertain end, which is where a treatment might be having a potential to reduce the risk, say, of recurrence of, single figure percentages. That's the case. And I'm not talking necessarily about neuroendocrine tumor disease, but other types of cancer. And the person's left with kind of there's a 95% chance I won't need to have this additional treatment. However, there's a 5% reduction or 5% chance of a reduction in my risk of recurrence years down the line. So am I the kind of person who can live with the decision not to have it because it's a 95% chance I won't ever need it? Or actually, am I the sort of person who's always going to worry that I didn't take the extra 5%? And I know that's one little example which is not necessarily relevant to you all, but I would still say, know yourself. What sort of a person am I? And whatever decision you make, know it's the best decision for you then. With the information you've been given, that's it. This is the decision. Bash. And a year, 2, 3 years later, know that you, I'm going to say must not, but that's like a command. Really, really try not to look back and think, bugger, I should have done the other thing. We can think of examples in our lives, I'm sure, not of quite such a serious nature, but decisions we wish we'd made differently. What's the point in looking back? We can't change it. Stuff it. So know yourself, share it with your nearest and dearest. This is the decision I'm making, and these are the reasons why. Whatever comes next, this was the best decision. And try and hold that thought. And I'm sure if you see other people going through similar, that's exactly what you would say to them. You made the best decision at the time, and that's that.
In the absence of any hands.
Sorry, I couldn't find my hand. Can I ask something, please, on
Yes,
that?
of course you can, Marcia.
Right. I'm here because my husband has neuroendocrine cancer, and it's been very rapid. And as you say, it's making that decision. For us, he was diagnosed in February, and actually it's become quite aggressive, and he's not breathing. He has actually made the decision today to not have any chemotherapy because it's not working. This is going to sound really strange, is that as a family, we've got 2 adult children. We understand the decision, but how do you get other people to sort of see where you're coming from? Because we've been through it, we've talked through it. We've been, I think, really good. Our adult children who are 23 and 27 have come to all the consultants' appointments so that they know exactly what we're being said. But it's explaining that to other people, because as you say, neuroendocrine is so different. It's taking that bit forward, and it sounds mean. People don't think and thinking that you're very callous. That's been quite difficult. I mean, for today, we've also had our GP do a DNR and stuff like that. So it's quite a thing. It's explaining it to other people. And does that sound weird? Sorry.
No. Marcia, first of all, listen, I reckon we'll all be thinking, I hope you have some time that is calm and comfortable. With no more malarkey from bloody doctors.
Yes.
Listen, I've never been, of course, in such a situation myself, and it's a totally different, of course, experience observing, being part of someone's care in a professional manner. And so I've had many a conversation with families about just this circumstance and the decision making involved. And I've seen, I think, so many times that feeling of being torn in two that you and your children are probably having now, and indeed your husband. On the one hand, none of you want him to go, but on the other hand, none of you wish him to stay beyond what he feels is reasonable and with potential difficult symptoms and suffering. That tension will be there. And the people who know you well and him well are going to be feeling somewhat of the same, and they will understand. I'm absolutely certain that, just as you've described to us, if there are people that you, as it were, confide in or know so well that you are going to talk to them about this, they will simply say, fair enough, we're with you. And if they don't, quite frankly, they can bugger off too, because then they're not the right people to have around. And I know we worry about what people think of us and say about us, but my feeling is, in these circumstances, judgments are not made. People accept decisions that their friend or their family member is making for themselves on the basis that is the best for them. And so
we've got to actually now tell the consultant as well.
Do you know, some people find that really difficult. I think you know, if you've made a relationship with
No.
the medical team, well, that's okay, Marcia.
No.
Oh well.
No, that's it's been a bit of a roller coaster. So that's been the thing as well, which I think makes it more difficult. But
right.
I've got to say that actually for today, for the palliative medicine, if anybody's list, we had in no time at all from the doctor, we have had so many phone calls and putting things into place that please be reassured the things that can happen are coming thick and fast. I mean, the doctor left at 3 o'clock and we've got oxygen arriving soon and everything. Like, honestly, it's like, yeah, have you got fire alarms? Have you got this? In that respect, after what we've had, that is a very positive element of it, that it's looking forward and how from our palliative service right from the start of diagnosis has been amazing. They've been really good and supportive. So it's just the change of gear for us now.
That's a really good phrase.
Yeah.
Change of gear.
So,
and I'm very pleased to hear you're getting good support, Marcia. Long may it continue.
Yeah, we will see. Thank you.
Yeah.
I don't know if it was your question that you put in, but we did have a question that was put in around stopping treatment, particularly when you do make a decision that the quality of life is what's most important. And I think, but I think sometimes it's difficult if you've got a medical team or friends and family who are saying, no, you must try something, you know, we've got this, we've got that, and everything, and you just think, actually, I don't want. And there seems to be this perception that if you make a decision to have treatment, that's an informed consent, but if you decide not to, it's the terminology, I think, sometimes doesn't help, does it? Because it's often put down as declined or refused, and it's kind of, no, I've made an informed decision not to go ahead. So I think we've still got some way with how we term things when they're not on that treatment at all costs pathway.
You're right. And listen, I think the doctor-patient, doctor-family, patient-family kind of intertwined relationship is really important. And there is definitely a feeling I've seen and felt and heard from patients and families that if things are offered and, as it were, kindly turned down, it's almost like an insult to the medical team, and people get upset or irritated or visibly angry. And I find that really hard as a doctor. I have to talk to patients about the medications, for instance, for symptom control that I have to offer, which are, let's face it, a bit like everything else we do in medicine, far less than perfect and come with all sorts of unpleasant side effects potentially. And I say, do you know what? If this causes you bother, bin it, and I will not be antsy about it because I know it can do that. And I will have to come up with an alternative for you. So you just let me know. And it must be that way. And particularly when we're dealing with far more, as it were, arduous treatments, anti-cancer therapies, and so on, the person going through it must be the one we listen to. And honestly, that thing about timing that's in the question really is so individual. And no one can judge another person's, as it were, quality of life or what they are able to deal with in terms of a condition that's causing them trouble or treatment that's causing them trouble. Only that person knows. And their judgment is the only one that matters. So I think be really open and honest as much as you can be with family and friends, and indeed clinical teams. And I hope what you will find is doctors and nurses and so on who actually say, fair enough. And if there's a particularly arduous therapy that's causing you bother, maybe there will be one that's less likely to cause you bother. It may have a lesser chance perhaps of benefit, but it might be acceptable to give that a bash. And they should listen to you.
I think that also, I think, maybe leads into we had a couple of questions about pain management, and I think it's the one thing that does, come up quite a bit. I think particularly because there is this sort of pain management sort of ladder, isn't there? Sort of, and often people are given opiates, but actually there's different kinds of pain, isn't there? And there's different ways of treating it. And I think sometimes it's let's face it, guys, we often talk a lot about poo, and we're very descriptive about it in the neuroendocrine
Love a poo
word. And we talk about the different types and the different causes and everything, but we don't tend to talk as widely around the different types of pain and the different ways that can be managed. And sometimes, if you've got particularly sort of neuropathic pain, capsular pain or nerve pain, sometimes that needs a different strategy, doesn't it, to some of the things that may be routinely prescribed. And I suppose, there's a couple of questions about, understanding pain medications a bit better, or maybe pain itself, but also sort of, sometimes you're in hospital and the pain relief's great. You get home and what you've been sent home with is not so great. So how can you optimize your pain management and understand how I'm throwing questions at you left, right, and centre here, sorry. But I think that whole issue of pain and how it's managed and having those discussions and finding out what information is helpful for you to know to understand the kind of pain that somebody might be experiencing, and what kind of things would you then think of to manage that pain and have a discussion about. Maybe
can I just say something? Sorry, I can't find my hand thing.
That's all right, Debbie.
For me, about pain is like, if you understand what your pain is, then it's not so frightening. And I think, you saw me before in a lot of pain, and I think I was in more pain because I was frightened. Am I dying? Am I dying? Should I go to hospital? I don't know. And when you explained it to me, then I can tolerate it. But it's not being able to tolerate it when you don't know, is this dangerous? Is my bowel blocked? Do you know what I mean? I know that's probably impossible to answer, but I suppose it's about understanding a bit. Do you know what I mean? I don't know.
Debbie, that's really important, because as a doc, in an ideal world, what we like to do is treat the cause underlying the pain or any other symptom. Of course, in my line of work, we're often not able to directly treat the cause, and therefore we are really using symptom control medication alongside any other, as it were, disease modifying treatment that specialists use. So I think that's the first thing. As a doctor, I like to know, well, why has this person got the pain? Now, clearly, a lot of my patients are heavily investigated with multiple scans and so on, and usually there is an underlying known reason for a particular pain. Not always, but most of the time. And then following on from that is, what can we do directly? Is there an anti-cancer therapy that might alleviate this pain? And if so, is it feasible to do that? And then alongside that, we will think about what painkillers, analgesic medications might be helpful, and bearing in mind what we've just talked about with side effects of therapies. What is a reasonable thing to try and do? But when I talk to people about their experience of pain, I try to understand the effect it's having on their daily life. And usually I start with the night time and say, can you sleep? Is the pain either stopping you getting to sleep, or is it waking you from sleep, or both? And then one of my first targets, whatever I'm doing, will be to try and help get an, if not undisturbed, less disturbed night, because that makes the day better. In the day, I will talk about things that people are able to do or not do according to the pain. So can you sit and eat without being disturbed by pain? Or can you watch a movie with your family without being disturbed by pain? Can you read a book? And then we go on to activities, essential activities like getting up and going to the loo, making a cup of tea, walking up and down the stairs, whatever it happens to be, before we go on to things like walking the dog, driving a car, work, and so on. And I try to then tailor medication to try and allow, I suppose, better ability to do all those daily things. It's challenging because I think, as many of you may have experienced, once you go beyond the things you can buy in Tesco's, paracetamol, ibuprofen, and then the combination medicines of paracetamol with codeine or dihydrocodeine, cocodamol, codidromol. Once you go beyond those, you end up with essentially either strong opioids like morphine, oxycodone, fentanyl. Sometimes we throw in some tramadol. Anyone here had tramadol? And did it send you off to the fairies? And there's some nods and some shakes. Yeah, I find tramadol really tough. Not personally, but when I've seen people try
Tramadol made me feel like I was hallucinating and
Yeah.
just different world altogether. Yeah.
Yeah, which might be a good thing, but probably wasn't.
No.
Yeah. So yeah, these drugs are not without hazard. And so in our aim to try and allow people to have a better day, sometimes we make it worse because you become so sleepy you can't do anything, or you get even worse side effects like hallucinations and confusion and goodness knows what. So it's about tailoring it to that person. And you mentioned the analgesic ladder. It's kind of a little bit gone out the window, but also it was never really truly designed for use in the UK. In all honesty, it was a World Health Organization attempt to make pain control across the world in developing world economies better. So we've always had the luxury in Britain of access to every medicine pretty much, and whatever dose you need, and there's no money involved on the whole. So it was a much less necessary tool to use, I would say. The other group of drugs that we often use, you mentioned neuropathic pain, is the gabapentin, pregabalin family. Anyone had those? No. They're not without hazard. Just because they're not called morphine or oxycodone doesn't mean they're easy drugs. And they also have now become controlled drugs. So they have picked up stigma and difficulties with prescribing, particularly in general practice along the way. People look at you in a funny way sometimes when you're on these drugs, which is not helpful. So they all come with pitfalls, but I think on the whole, we can make a difference to that daily life, be it helping people to sleep better at night time and maybe being able to be a bit more active or concentrate on things they wish to concentrate on during the day. So it's about individualizing it as much as possible to that person, the timing of their pain, what brings it on, and so on. But I think it would be foolish to promise, we can make people 100% pain-free, because that's rubbish. The only thing I can do to make you 100% pain-free is anesthetize you, really, and make you sleep the whole time, which, of course, is not practical or helpful. So, tricky. I think there's a bit of perhaps scandal's a big word, but it's a bit shameful maybe that's a better way of putting it, that if you look at all the medical technological advances, both in diagnostics and therapeutics in my lifetime as a doctor, medicine for pain has hardly changed at all. And if you go back 3,000 years, hasn't changed much since then either. You know, we were using poppy juice back when, you know, the ancient Romans, Greeks, Chinese, Egyptians were already practicing pretty good medicine. And we haven't got a lot further in pain medicine, which is pretty poor. So really important to find someone that you can talk to in detail about the pain experiences that you have, and for them to try and home in. There might be, of course, more than one site of pain, so you might need different things for different pains, and individualize it. And a principle is, if you're starting on some arduous medication in the form of morphine, oxycodone, and so on, or the pregabalin, gabapentin family, go low, go slow, and titrate upwards. And you monitor both the good and the not so good. When you're at home, obviously, there might be quite a time in between follow-up appointments or phone calls. Keep a note of the things you experience, both the good and the bad. So don't forget, definitely, pain may respond to anti-cancer therapies, be it local radiotherapy or systemic therapy. So if you pick up a new pain, get on the blower. So I've got a new pain. What can you do? Might need another scan, might need some radiotherapy, that sort of thing. And hopefully there will always be something that we can chip away with.
And I think, Debbie, your point about understanding what might be causing it, because I think that how we maybe interpret pain before being diagnosed, and how with a cancer, and how we may interpret aches and pains that may arise after you've been diagnosed can be different, because beforehand, particularly if you've no suspicion that you may have a cancer, it could be the last thing you think of, but once you've been diagnosed, it's often the first thing, and that can lead to anxiety. So I think it's kind of understanding. And I think it helps, maybe, as you said, Phil, talking with your medical team and you know, about maybe what to look out for or what might happen, so that you know then what to report, because I think that's another thing where you're not sure what and when, and some people will wait until their next appointment, which could be 3 months, 6 months down the line, whereas others will you know, contact more quickly. So
spot on.
I think the problem is that I've noticed that I was having terrible pains in my stomach. Now that's changed. So it changes, and I've learnt, like, just live with this for a bit. Do you know what I mean? Like, I was going to bed with all I've got is paracetamol, but I just found sleeping was good. But those pains have passed, and now I have different. Do you see what I mean? So it's not worth contacting the team, because, you know, sometimes I just think, oh, it'll just, you know, pass in a couple of weeks or something. Do you know what I mean?
Yeah, I think if it's sudden or new or worsening, then it is always worth dropping a line through. And I think the other thing, depending on the type of neuroendocrine, is, so for some of you that may have small bowel primaries, is, you know, with the way that a small bowel primary can affect it, is sometimes dietary adjustment can actually help alleviate the pain rather than necessarily analgesia, and managing sort of the diarrhea or your diet, you know, particularly if you may be at risk of obstruction, you know.
Everybody talks about diarrhea.
I know, but constipation's the other big thing.
and you know, and that sort of thing. So I worry. And then I'm managing it. You know, I've discovered eating pineapple really helps. And then a couple of weeks later, that's not working. Do you know what I mean? It's like, it changes. Like every day is different. I think, oh, well, that's exciting. At least every day is different. But, yeah, don't know.
Can I just say, I've
Last-
got to agree with Phil. I would tell the palliative care nurses, because David right at the start was having headaches, and he still has headaches.
Mhm.
But rather than go to paracetamol, they told him to have, did he like tea? And he said yes. And they said, do you drink decaf or caffeinated? And he went caffeinated, thinking they're going to say, right, you've got to have decaf. They said, no, carry on with the caffeine, because it opens the blood vessels. And that's that one little thing of saying to a nurse, oh, well, his headaches hurt, and she came out with a cup of tea. That's actually our first port of call with a cup of tea is, we'll get you a cup of tea, then we go to paracetamol, and then we go through. So I think sometimes mentioning, as we had with a palliative care nurse, saying, oh, the headaches, it's such a simple thing, but the number of times that it cuts it down right at the start is a really good one. So I would just say that what we found is it's these little things that make life, that you would never think, have a cup of tea. Yes, we're completely British, but yes, have a cup of tea, you know, and that's it. So there's me on the decaf because I've got heart problems, and he's on the fully fat. Use that tea bag and get that caffeine out. So yeah, it's sometimes really simple things we've found.
Veronica.
I was just going to say, like how everything changes. The previous lady was saying that, and I have to have a low residue diet, but I also now have become diabetic, being on lanreotide, I think, and then I was taking Creon, and I'd got to the point where I thought it was all working, and now with the shortage of Creon, and then I was given Pancrex in capsule form. Then they couldn't give me that, so I had powder. And then this week, so I was eating much less with the powder, but in actual fact, my tummy felt better. So I was like, oh, this is all right. And I got Creon last week, and since I got the Creon back, I'm struggling again. So it's I find it exhausting, trying to manage, remembering what medicines I need to order, first of all. And I think, and I hope I'm quite at the start of my journey through all of this, I believe, but that part of it is like, as well, that I'm able to remember what medicines I need to order, but then when you try to order them, they're not available. They give you something else, and it's totally messed it all up, and I feel like I'm back at the start. So it's just totally agree with that. It changes, and sometimes for the better, but sometimes not so good. So
Yeah.
I was so delighted to get the Creon because it's so much easier to take than the horrible powder. But I don't know if I've just not been taking enough, or I got overexcited and ate too much, or I don't know. So
Keep going, Veronica. Keep juggling.
yeah, that's what it feels like.
Find the balance.
But in the plates round about.
Yeah. Oh boy.
Kate, you put your hand up, but put it down again.
I was just going to say, Philip, we've talked previously about the respect form. Could
Yeah.
you talk more about that? And also, we've got Sue here with us, who actually deployed very successfully the respect form, and she's happy to chat about how it worked for them as well.
Ah,
Do
okay.
you tell us that might not know about it, how it works?
So, interestingly, in the Royal Free, so we don't use the respect form. We have something a little bit similar called a treatment escalation plan, which covers some of the same, if not all the same aspects. And then in London, I was actually going to mention this. For those living in London, there is a web-based platform called the Universal Care Plan, which is again really replicating what the respect form was aiming to do, and that is to record a plan for as individualized to that person around what they would not wish for under certain circumstances. Records things like the DNA, CPR, decision making, whether it's been made or not, where they would like to be, should things take a turn, as in back to hospital. Really, under no circumstances do I ever wish to darken the door of ED again. Or sometimes I would, and sometimes I wouldn't. I think what they all have in common, whichever, as it were, pro forma, platform, form that you use, it's really important to say it's made at a point in time where actually we don't know truly. We can make a good stab sometimes at having a good idea of what we might wish for or not, but come a day when a complication occurs, really, if you're able to say, actually, this is what I wish for or not what I wish for, then that is the most important thing, not the form or the web-based platform. The decision is yours on the day. Of course, if someone's lost capacity, then we would fall back on any previously expressed wishes or decisions that have been made and listen to the nearest and dearest, importantly. Sue, does that sort of ring any bells with regards to respect?
Yes, it does, definitely. We had no idea that such a form existed until the very first visit here from the palliative care nurse. And she happened to have one with her, and she encouraged my husband and he was back then fit enough, well enough to be able to put these things in place, which I can only say is so important, because the form, we then took it to our GP and Ian filled it in with the GP, who then signed it off. I took a copy and put in his notes, and we brought the original home. Ian had end-of-life care at home, which was his wish, and thankfully we were able to carry that out for him. And there was a folder here that the district nurses and the hospice at home team used. They had his treatment chart and everything else, and right on the top of that folder was always the respect form. And twice a GP came and said, Ian, we really need to get you in to hospital for a day. We need to drain this fluid. We need to do this. We need to do that. And Ian was absolutely adamant, and he'd been in hospital. Cutting a very long story short, he'd been in hospital an awful lot over the 2 or 3 years before he passed away. And he was determined that he wanted to be here at home with me. And thankfully, that was how it worked out. But if I wasn't aware of the form, then I became very aware of the fact that probably a lot of other people aren't aware of this form either, and how important it is. It's probably, I would say, as important as having a will and having a power of attorney, because in a sense, it's still classed as a legal document, which means that the patient has the final say on what they want or don't want. And Ian's case was, his biggest dread was going back into hospital. He could not face that. So it's since become very important to me to raise awareness of this and to encourage everybody that while the patient is still able, well enough, mentally fit enough to deal with these things, put it in place, then put it in the file, and you know it's done. And you've then got peace of mind. And I could then focus on his care and only his care. I didn't have to worry about anything else. And that's been my experience. And I just wanted to pass that on because it's important to me. Thank you for the opportunity.
Thanks, Sue.
Thank you, Sue. I think I should take you with me wherever I go. So, listen, I think you made some really good points there that I say almost exactly the same way. Peace of mind being one of them. Yeah. However, Sue, I also acknowledge that not everybody is as open and able to have these conversations as you and your family and your husband, and therefore I think sometimes as clinicians we go gently and we don't ever get there, which might be wrong. And sometimes I'm sure it is wrong. But other times I think it is again, it's about, well, as the form implies, respecting that individual's approach. But I'm with you, and I hope when it's my turn, no idea how I will feel, but I hope that I am able to make those decisions in advance and have those discussions with the people who hopefully love me, if there's any left by then. So I do think it helps me as a clinician when I'm talking to patients and families about everything in an open way. I feel that the care we can give is better for that. And I suppose in a way that's a selfish need on my part. I've seen some beautiful things in my time in terms of conversations between people who love each other. I've been privy to that. And it's, how can I put it? Yeah, it makes me really appreciative of humanity, just to put it really grandly. So eyes open, looking into things. Sometimes, Marcia, if I may say, a bit like with your husband, as it were, not thrashing against the current anymore. Just swim with the current. Sit back, relax.
I've got to say,
with it.
I've got to say that with Sue, I know exactly what she means. We're getting to the stage now that everything will be in place, and then that's it. We can just look and enjoy the time we have left, and that's the most important part of it, is enjoying each day as it comes along.
Yeah.
So yeah, it is. We literally did the universal care plan today. We've done ours already, so yeah, that was a good thing to do. So it's all done. You just don't have to worry about that one.
No, exactly.
And it's really quick. As I say, our doctor came, he must have left here just about 2:45, and by 4:30 I'd got a copy of his universal care plan. So yeah, it's done. That's how quickly it can be done.
Yeah.
It's interesting though as a topic, isn't it? Because I did mine 2 years ago and I found that it just brought me peace of mind because I just forgot about it. I've done it. I've decided, and it's in a box with my will and power of attorneys. Done. I don't think.
It was quite nice because he said with the one in London that when an ambulance, if you call an ambulance, they will know about the DNR and things like that. And that was really good to think, oh, you don't have to. It's the going in and explaining at times when you don't want to. So that was a good thing to do. It's just one less thing.
Exactly.
Yeah.
Can I just say my heart goes out to you, Marcia, because I've been where you are now.
I don't. You're a very brave woman, so bless you. We just, as Philip said, it's getting the family all on board, which we've been very lucky to do, and and we've found talking things through in different ways, that we've all had different conversations between us as well. And actually, one of the best things was going away for a few days and then coming back and talking, because we forgot about cancer for a few days and then came back, and you've relaxed a bit, and that was a better way as well to do it.
Yeah, exactly.
I think the other thing is about clarifying. I've talked about terminology before as well, but clarifying is we've got the respect form, and you've mentioned that this treatment escalation plan, we've got the universal plan, we've got the advanced care planning, and I guess it's about being clear on what. I think for some people, one of the questions is about, there are all of these different terms, there are these different forms, which ones basically just state your wishes, which ones are legally binding, about even if it's an eventuality, you know, that isn't imminent, you know, sometimes it is about, you know, when's the best time to make those plans, and again, maybe it comes back to being the sort of person you are, but I think, you know, yeah.
So I think essentially the legally binding version is called the advanced decision to refuse treatment, and there's a pro forma, and it's a bit like actually making a will in the sense that it has to be signed, witnessed, and dated, and all that malarkey, and that is legally binding. So if that's presented to a medical team, and the important thing is when that person's lost capacity, then the medical team are obliged to follow that person's wishes. Now, important to say is an advanced decision to refuse treatment. What doesn't, as it were, have the same power or weight is an advanced decision to request something, because as it stands in the UK, a medical team is obliged to follow the refusal made in advance, but it doesn't matter whether the person's got capacity or not. We're not obliged to, as it were, give people whatever they ask us to do, and you can imagine there are reasons why. That would be like pick a mix, you know, that would be a bit dangerous. So that's the legally binding way of doing it. If you go down the lasting power of attorney route for decisions around health and welfare, then as long as that person or persons represent your wishes as you wish them to do, then that is powerful, but not absolute, because there's still a conversation to be had before a decision is made. So I think whatever you do, be it an informal conversation or lasting power of attorney or an advanced decision to refuse treatment, the most important thing is having the conversation in the first place. If you have capacity, all of those things are irrelevant. Previous conversations, wishes, and so on. It only becomes relevant if, sadly, one has lost capacity. I've actually I did prepare some handy links on just those kinds of things, which I can share. I can send them to Nikki and Katie, and they can be
I'll share them with everybody.
Shared with the group. Yeah, but I've nominated my wife and my children, as she has done as well, for all these things, and they all know how we feel about the what ifs. Yeah, my youngest son was very reassuring. We said, "Yeah, don't worry, Dad, I ain't going to look after you. I'll sell the house, put you in a home." So got that all buttoned up.
Farming.
Yeah. Oh dear.
And my son, he said, "Don't worry, Mum, about allocating stuff." He said, "If you go, I'm just going to burn the lot."
Yeah, equally reassuring,
isn't it?
Yeah.
Teresa, you've got your hand up, and then I'll come to Philippa.
Yeah, hi. Yeah, I just wanted to talk about, I put it in the chat, but when you've got it, what I find quite challenging, obviously I've seen you a couple of times, but that was a while ago, and I don't know if you remember me, but obviously I've you know, things have changed a lot since I last saw you.
Yeah.
You probably ain't aware. I don't know how it all works if you get updated with information about patients and stuff. So it's I've just got used to living with pain, and as the pain gets worse, I just say, okay, the pain's getting worse, because obviously I know why it is and what's going on and all the rest of it. So I just change in my head. My resilience goes up and up and up, and some of the things like what you say about can you read a book and not be in pain, can you eat your dinner, or can you sleep, and all those sort of things. I mean, I never really thought of it like that, because sometimes when I say to people I can't drive, because one of the reasons why I say I can't drive far distances because I'm in too much pain. And people don't, so you're sitting in a car, you ain't doing anything. I find it very difficult because people don't understand, and it's quite exhausting trying to explain to people all the time why. And also when you've had an illness, for me, obviously, because it's been quite a considerable time now, the longer, sometimes I think the longer you're ill, people forget that you're ill.
Too right, Teresa. Too right.
And because you've managed so well, in spite of all the complexities and all the rest of it, they just think, oh, you know, you just up the ante every time. So it's very difficult, like I said in the chat, that especially when you've got another illness and you're on medication for that, then they say, oh, just take that and take that, because that will help. But my first response is, well, how's that going to affect the other drugs that I'm taking at another hospital? And that's one of the things that I think that needs to be addressed, because when you go to clinic, they only deal with NET. They don't talk about anything else you might have, which to me, I'm one person and it's all happening in the same body. But that gets lost because when I go to my other appointment, then they say, oh, what's happening with NET? Then you have to explain to them what's happening. And then they say, well, we're going to have to change your medication because of what's happening with the NET. And then you have to carry all of that burden. And then you have to explain all of that to the NET team. And then it just becomes this vicious cycle of information. And then you just think, well, who's going to be the one to know, well, that if I take that, is it gonna do anything to any of the other treatment? So my issue is I'm not going to take it because there's no one overseeing that part of it, the other comorbidities. And I think it's a massive thing because lots of other patients do have other illnesses. I mean, I'm not so much talking about the diabetes that's been caused by the analogs and things like that. I'm talking about just generally other things that they had, like I had before I even got NET. It's you just spend all your time in different clinics with different doctors, and there's nobody in the middle to work it all out apart from you. But even though I know my body, I'm still not a clinician. I might do a good job of explaining stuff, but you know, at the end of the day, I don't really know. I don't know, but sometimes I think because I've been around so long, people just assume that you know, and it's caused all sorts of problems because you're trying to explain things to different doctors about different treatments that you're having somewhere else, and then it's just very exhausting, and so you just end up just saying, "Oh, just forget it," and just grin and bear it, which is what I tend to do. And family are quite like that lady. I mean, I give credit to you because for you to come on and talk about that, what's actually happening to you now, you know, you've got such courage, because I don't think I could do that. But when you've got a family that everybody's struggling with what's happening to you, and you have to be the one to help them manage what's happening to you, you just think, I can't, who's managing me? So all of that kind of issues in the palliative care side of it, it's not just the team at your NET team, it's all the different other people in the NHS who might say, oh, we need you to do this, but why do you need me to do that? But my biggest concern is there's no communication with all the different people in that, because the GP sent me a text message, oh, you need to do a urine sample because one of your things is up. Where did that come from? Don't even know. Have they spoken to the free? Have they spoken to somebody else? but they want you to do it, but you don't even know why they want you to do it. And are they going to give this information, and what's the information for? So it's not just the net, it's all the other different organizations who want to know information about what's going on, but then nobody's talking.
Teresa, I think you've kind of summed it up, I think, in terms of the enormous flipping machine or monster that the NHS is, and how difficult it is to have clear and reliable communication between different teams, even within one hospital. It's a challenge, let alone if you're going to multiple hospitals and you've got the poor old GP in the middle who's getting letters from all of them telling him to change the medication to this, that and the other. Honestly, you need a conductor. And I think you've hit a nail on the head. In the end, you become the conductor. You become the one who is passing on the information. I bet you are. I bet you've had enough. Yeah.
And
yeah.
You know what happened, Nikki? After I came off the Zoom, I rang up about the Nutrizyme, and they said there isn't any, and she told me get it from the hospital, and she was so rude, and I just thought I give up.
Yeah. Oh dear.
It's bad enough having to deal with the illness, but you've got to deal with all the bureaucracy. You have to be an advocate. You have to be all of that. And when you're in a miserable mood, which understandably you would be after dealing with all that, you get kickback because of that. And you just think,
yeah,
well, where's the peace? Do you know what I mean? So it's not helping an already distressing situation. I you know, sometimes you just think, oh, how long can you sustain all of that and keep doing it? But you try and keep doing it because you have to, because it's about you. But like you said, doctors don't have the time to talk. Understandably, like you said, you've been waiting in clinic an hour. You know, you've got 10, 15 minutes. You may not get the same consultant that you usually get. It's a whole, there's no rapport with certain doctors or practitioners or whatever. So you're in this constant wheel of distress sometimes. And you just want to get off, the wheel, don't you? And get the best result. But I don't know. I don't know if there's some sort of webinar that we could do, and all the different people were there, and you could just say to them, listen to what we're saying, and you know, an MDT of patients talking to the staff about what it's like, you know, instead of have the actual patient in the MDT and then talk to them all about it.
What a novel idea, Teresa. Goodness gracious me. The patient talking about the right decision. That's a ridiculous. No, come on, that's never going to happen, is it? Do you know, the MDT thing, it's always been a bugbear of mine that you get a bunch of specialists in a room together from all the different fields that you need involved: radiology, pathology, oncology, gastroenterology, and a few others. The one person who isn't there is the most important. That's you. It is just so frustrating. Teresa, listen, you're very experienced now, sadly, and I don't think I've got an answer for you, but I do acknowledge just what you say, that it gets so complicated, and what we don't have for, well, I want to say for anybody, but almost anybody, is that coordinating person, be it a specialist nurse or one of the medical team that you're involved with. But I think that's what it needs. And every time there's a change or a proposed change, that person then does exactly what they should be doing, coordinating with everybody else and saying, is this okay? Is this okay? Because, you know, we do use medications for different indications that may well have an effect on, for instance, your ticker or your renal function or your diabetes or whatever else it is that you are having to deal with. And yes, it can get overlooked. Pharmacy, as in the hospital pharmacy team, can be really useful. I don't know if anyone's come across that, working alongside particularly oncology teams, renal teams, palliative care teams sometimes. A pharmacist is there to stop me poisoning the patient, and they can be so helpful and tell me, yeah, Phil, don't do that. I think they are a sort of underused sometimes resource for us. So Teresa, stick at it. Keep on coordinating. Telling everyone what they should be doing. I think that's entirely reasonable. Philippa, you've had your hand up for ages. I do beg your pardon.
Hear me?
Can hear you very loud and clear.
It keeps saying that my microphone's not working. Basically, I'll tell you something, that MDT thing, I wish that was the case, because I've just gone through 4 weeks of hell. We've been told something had rapidly changed and the MDT had seen this, and I knew that there's something wasn't right. And in the end, the consultant brought the radiologist down, spent ages going through my scans, only to find that this large mass in my peritoneal area wasn't that at all. It was my fibroma and fibroid from 2013. And I'm thinking, if only I could have been at that team meeting, I could have actually put my queries up there and then. You know, it's difficult. My question is basically, I do not know what my end is going to look like, or I've not seen other people go to them. So is a respect form, can you do it instead of a power of attorney? Because I'm just about to do one or the other, and I only have a husband. I don't think he understands, and I just feel it's such a burden to put on anybody to actually have to make decisions on your behalf, which the power of attorney seems to suggest that's what they're going to be doing. So this respect form sounds kind of better.
I'll show you it. Hold on. Oh, I can't.
Oh, hold on. I'll like.
Yeah, my sharing is disabled.
Because
I'm a loose cannon.
Not anymore.
Yeah. I sort of feel like, you know, I'm saying I wouldn't want this and I wouldn't want that, but I've never seen anybody going through it. So I don't really know what I would say.
Philippa, can you see this? This is an example form.
This is
so it's only two sides of A4, and it does need a bit of thought, because as you can see, the free text boxes are not huge. So section 2 is about your particular condition, and then if you've made any other form of advanced care plan and so on, ADRT, advanced decision to refuse treatment, or if you've got a lasting power of attorney already nominated. And then it talks about things that are a little bit, what's the word? Spiritual in a way. What's important to you? And then the things you really wish to avoid, which might be returning to hospital or an ITU admission and so on. And then when you go to section 4, it talks about clinical recommendations for emergency care and treatment. So this is where sometimes you need to be with a clinician maybe to talk about those things. And as you can see with the respect form, the clinician actually signs it. So it could be a palliative care team, it could be an oncology team, or some other specialty. A GP could do it with you. If you know that GP well, they know you well, you've got that relationship. And that would be then about specific medical interventions like attempting CPR, for instance, or admission to ITU, ventilation, those kinds of interventions that are quite, well, traumatic and scary. So I don't think this is a do-it-yourself form. There are other versions that are not called respect, and they're not, as it were, almost so clinical. And you can I think I've in my in my slides, I've actually got some links to things that might be useful. You can even just a statement of preferences and wishes, Philippa, that would help. For instance, if your husband found that he was being asked, what would Philippa wish for now, and you've lost the ability, the capacity to take part in the conversation, he could say, well, do you know what? She wrote this all down. And then he would not have that burden, as you say, of responsibility. I do think that it is a challenge for families when a person has made these decisions which are best for them, but not best for those around them. And I think judgments can be made about, oh gosh, giving up, lack of courage, lack of fight, all that kind of pejorative language that can be used. Let's face it, in the media, when you see the report of someone who's been through a long illness, they talk about fortitude, courage, bravery, and so on. Well, is the opposite true? You know, if you decide not to have a certain therapy anymore, and actually you don't want to go back to a hospital, is that the opposite of bravery? Well, I don't think that's the case at all. In fact, I think it's more brave if we're going to use the word, but I try and avoid it completely and don't talk about bravery, fight, courage, and so on, because it's a bloody nonsense in the end. You know, we're lumbered with what we get lumbered with. It's not a choice. If you go into it, as I say, able to discuss openly the things that are happening to you, the things that you fear, not the opposite of bravery. Naturally, things that you are worried about, these things might happen to me. It makes it, I think, more likely that the care given will be what's best for you, and stipulating things you definitely don't want are really, really helpful, and actually absolutely can relieve the burden on your nearest and dearest if that time comes when they're involved in the discussions. If you do go the formal way, Philippa, of perhaps nominating a lasting power of attorney, again, just going back to what I said before, just make sure they know how you feel and what you would and wouldn't wish for. Thank you very much. And I think in most instances, that thing about love is that they will do what they know you wanted and not what they would really like.
As well as they know you, I've always thought these family, as somebody's in a vegetative state and somebody plays them the right music and they come out of it, I wouldn't put my husband in. I don't think he'd know. I could tell him all I like, but it's just, some people just don't take it. And I really worry that, I'd be lying there, not able to say anything, and somebody putting completely the wrong thing on and torturing me.
So, do you know what? There's even out there things along the lines of preferences, statements and wishes, preferences for care, where you can stipulate things that you would like to be played. Literally, what music would you like? If there's any spiritual, religious need for, prayers and so on, you can stipulate that. And hopefully, if someone is caring for you and you can no longer speak for yourself, those things will happen. Yeah, I mean, imagine going out to, I don't know, Tom Jones.
When I did mine a couple of years ago, there's also a box to stipulate who you don't want around you. And that's an interesting one to think about as well, because with the best will in the world, there might be some people in your family or your close circle who are not a calming influence and are not who you would want then. And that made me think. And the other thing, Philip, was interesting. My GP pointed out to me when we were talking about how you would want to be resuscitated, if you wanted to be resuscitated, she made me think about if you had a road traffic accident, like any of us here could have, you would want the same standard of care as the next person on the street. But if you were incapacitated through your cancer, you might want to state your wishes because it was end of life care, which is very different to being hit by a bus. So
I concur. So one of the things that we do come across is for people either living in their own home or in a care home, a sort of blanket I never want to return to hospital, and then they fall and they break their hip. Well, how the hell can you manage that in your own home or in a care home even? And so there has to be some recognition that it's not always possible to really follow every request. And I hope that's a reassuring thing rather than a scary thing, because it would mean that, for instance, if you've got a really complex set of problems, but you haven't got capacity to talk about how you would wish it to go, that the people around you who love you, and indeed the clinical team, will make the best decision for you. And that might mean caring for you either in a hospital or a hospice setting, and making sure you're as comfortable as possible, even if your preference was to be at home. And I think it's reassuring for people to know their family will also therefore be cared for. I've just got something on the Macmillan website, which again I've got a link for, which I'll show you, Philippa. It might be a little bit helpful.
Can I make a point about some, this idea of lack of capacity?
Yeah.
We had an issue with my mum. She's 99 next month, but last year she broke a pelvis, was in hospital.
Yep.
She's got cognitive impairment, as people do. And then they put her on morphine patches and some other painkillers and something else. And she was then deemed to not have capacity. She was thrown out of the care home and we were told, well, we'll put her in one because I didn't want her to go back to her house. Then she was sent to a more secure one because they said that. And as soon as we weaned her off these painkillers that nobody was trying to wean her off, she was back to where she was. And meanwhile, she'd been through complete trauma. And does it often happen that people, she was wandering without knowing she was wandering? Does it happen with younger people where they put you on these drugs and then you suddenly appear to have lost capacity?
That's a really good question. I'd say it's less likely. I think the medications that we use for pain and other things are far more likely to cause difficulty with confusion, disorientation with elderly people. Essentially, as we age, of course, all of our organs become less robust. So imagine, I'm trying to think of a good example. I often liken how we function to a tightrope walker. So when we are of an age, like your mum, in a 10th decade, for goodness sake, wow, your organs are all working, but they're on a tightrope such that if you literally have one small insult, like a flick, you lose your balance. One small insult, your organs can't cope, be it your kidneys, your liver, your lungs, your heart, and your brain. You can be well functioning in your own home, able to care for yourself, do all your daily tasks, and then you get a small infection and whammo, you're completely disorientated and you're confused. And similarly with drugs, that you can easily cope with when you're robust in your 30s, but not so when you're frail and on the tightrope when you're in your 80s and 90s. And so, yes, it can happen, Philippa, that we doctors, through our treatments, can render people incapacitated. I would hope, didn't happen with your mum, I know, but I would hope that most of the time we recognise when we've done it or when something else has done it that we're trying to treat, like, your calcium's too high or your sodium's too low or your glucose is too high or too low. We can correct that, or it's an infection that we can treat with antibiotics and hopefully get that person back to where they were. And if we're making decisions about long-term care, then it's incumbent on us to do everything we can to include that person in the decision making, and that means trying to reverse any cause for loss of capacity or confusion. And I'm sorry you had that experience. I wish I could say I'd never done it, but I think I probably have. So this that I'm sharing now is from one of Macmillan's booklets, really, and this is the thing I was talking about, preferences and wishes. Really, it's called it priorities, and you can add things in here that are not exactly medical, but for instance, place of care. But you can also add things like, this is what I want around me. It's quite a long old, you can see it's 80 odd pages, this booklet, but it's got quite a lot of useful information and examples of this kind of thing, forms and so on, that could be helpful, especially if you're having a good old conversation with your family. It might be a good template for a conversation.
Thank you.
What's the difference between the care that you get in a hospice, the end of life care, and the care you get if you was, say, in a hospital?
Such a good question. So I think one of the key differences is environment. How many of you have been admitted to a hospital and got a good night's sleep? Yeah, right. Yeah, you never go to hospital for a rest, do you? Hospices are far more likely to have an environment which is calm, peaceful, usually single rooms, not universally, and an environment which is therefore much more conducive to families, friends, visitors. That's key. And then there's the emphasis of the care. In the hospital, the emphasis will not necessarily be solely on your comfort, but on observations that might be meaningful or not. Monitoring your bowels and bladder in a way that is about measuring quantities, not quality. Blood tests that you have every day and you wonder why, because nothing's changed since yesterday. Oh yes, and another scan despite the fact I had one last week. So the emphasis is totally different on what can we do to make this person as good as they can be without recourse to things like daily blood tests and scans and so on. There will be medical care that will be specialist palliative medicine doctors who are hopefully pretty good at using medication, as we talked about before, individualizing it to the person. Teresa, in a hospice, there's time to consider all your other conditions, not just, for instance, the neuroendocrine disease. And we should look out for interactions with different medications or influence of drugs on other conditions, and have the time to really focus on that. And then there's, I think, the wider team around you. Hospices usually have, hopefully, everybody you need, be it physio, occupational therapy. If you're thinking about getting home again, what equipment might be useful, what rehabilitation can we do now? Then there's social work for things like benefits advice or housing advice and so on. And then there's the psychological, emotional support of either counsellors or, again, social workers who are trained in that type of therapy. Some hospices have psychology, not all. So for more, as it were, complex interventions. And then there's chaplaincy. So looking at that individual's spiritual needs and indeed that of their family. For the family too, we sometimes may perhaps be involved in preparing for loss, particularly if there are children or grandchildren that are, of an age where they need some help. So I think that's probably what I would say. It can be a place where clearly people may spend their last days, weeks, but equally it may be a place where you go in for a period of time in order to control a particularly troublesome symptom, be it pain or something else, and you go home again. Some hospices offer respite care. So if you're fairly dependent on the people around you for daily tasks and so on, and actually they're going on holiday or they're cream crackered or they've got to go into hospital for an operation, they can offer a respite stay. And then there's rehab. So if you've been through arduous therapy, surgery, chemotherapy, radiotherapy, or an arduous complication of your illness and you need a couple of weeks before you go home from the hospital, then a hospice can sometimes step in and give you that time and rehab, hopefully get you back up and able to leave. I'm rattling on now. I sound like an advertisement, but far too long. Deborah, you'd like to ask a question?
Yeah, sticking with the hospice bit. I knew I couldn't go for the whole webinar without asking a question. Sticking with the hospice care element, what worries me is that we're considering future options and what our desires might be. Many hospices are actually shut in, as I understand it, because they're charities and there's not much money and they're not funded by the NHS, only by about 30% or so. And your hospice closed for a very different reason. But I don't know, what can you see the future of hospices? Because it does worry me that we kind of think, oh, that'll be there for us to control and respite. But actually, will it?
Yeah. I absolutely agree with you.
Yeah.
I'm not. Listen, depending on where you live, of course, there might be more or less of a chance. Not everywhere has access to a hospice in the UK. There are reducing number of beds, as you quite rightly point out, through various reasons, but mostly funding. Staffing has been an issue for many years. Hospice beds have reduced because we just can't staff them, particularly with nursing staff. It's really challenging. If you look at, not to be too morbid, but if you look at the place where people die, in the UK, the percentage of people dying in the hospice of total deaths has never been more than between 5 and 7%. So if you think about choices, it's not really a choice. It could be a wish, a preference, but it's not something that can be guaranteed, unfortunately. Far more people die in their own home, about 20 and a bit %. And then care homes, residential homes take up about another 20 plus %. Hospital is still the place where most people die. About, depending where you live, between 48, 56% of people will be in hospital. If you have a predictable, as best as can be predicted, cause and a predictable course of a decline, and you are supported, not living alone, in other words, and you're known to the local community palliative care team, district nursing team, you've got carers in place, you've got the equipment that might be used for hospital bed and so on, of course your chances of staying where you want to stay at home are higher. If it's anticipated, I think if something happens unanticipated and all those preparations haven't been made, it's so difficult to get things in place for you. And so that, I think, is key. Anticipating, having conversations, and if things are changing, making that known as soon as possible and being reassessed. Thinking about some of the things we've talked about already, making sure that wishes and plans are documented and shared across, the whole range of health services, ambulance service, GP, district nurses, hospital, all of them know what the plan is. It's so much more likely to happen. Even then, there will be the unexpected. Your nearest and dearest can get ill, and that will just, blows it all up in the air. Or as I say, you can have a fall and break a flipping hip, and then it stuffs it up completely. But you can only try. You can only do those things that are possible to do. But yes, I think hospice funding is an area where there will be some campaigning you might be aware of in your local area or even nationally. And so if you're involved with your community palliative care team that are probably based or at least very linked with a local hospice, then talk to them about it and see if there's anything you can do. Badger your MP. Listen, I'm not saying that there will be a change, because I think this government is hamstrung with the financial restraint, and they're not going to go mad beyond what the previous government, as it were, fixed in terms of spending, and I don't think there will be a wild change in terms of palliative care hospice funding. But if we're talking about it, it's more likely to be on the political agenda.
Okay, thank you.
Okay.
I'd like to say thank you. I think I've learned a few things tonight, to be honest. And actually, I really admire all of you for talking, listening, asking questions and being so open, really. Yeah. I hope I'm like you.